Hi, good afternoon, everyone, and welcome to Integrating Health Equity Language into Funding Opportunity Announcements. This is the first webinar in the webinar series, New Tools to Advance Health Equity. My name is Mary Ann Cooney, and I'm the Chief for the Center of Population Health Strategies at the Association of State and Territorial Health Officials, and it's really my pleasure today to have this opportunity to share with you and for you to listen to some folks that have been using tools to advance their health equity. The guide that you're going to hear about today is meant to serve as a resource for state health agencies that are considering incorporating health equity requirements into their funding announcements. ASTHO is committed to supporting state health agencies in their work to address health disparities and advance health equity, and this is one tool that you'll be hearing about today that will help us do that. Today's webinar, the speakers will describe federal leadership on state and regional health equity initiatives. They'll provide specific examples of how a state health agency has incorporated health equity language into its funding announcements and describe the new tool for health equity developed by ASTHO and the Health and Human Services Office of Minority Health. Throughout the webinar, we will feature poll questions, and attendees will be invited to ask questions via chat only. The lines will be muted for the call, but there will be time for questions after each presentation. Questions that are not answered through the chat or via the web today will be answered after the webinar. One of our speakers has to leave directly after she speaks, Sunseri, from the Director of Office of Equity in the Director of Program Operations at the Office of Minority Health, and she does have to leave today, but we will follow up with her on any questions you may have. So let's go and get started. Our webinar is being recorded. As again, I said, my name's Mary Ann. I'm the Chief of the Center for Population Health Strategies, and I oversee and provide strategic direction for the Center's 3 pillars for population health: clinical to community connections that advances primary care, public health, and human services integration, health data analytics and informatics, and on the topic today, health equity and the social determinants of health. We have our first speaker will be Sunseri Cobb Souza, is the Director, Division of Program Operations at the Office of Minority Health at the U.S. Department of Health and Human Services. Ms. Cobb Souza leads OMH's DPO's development and implementation of public health programs to reduce health disparities, improve quality of care, and increase the diversity of health-related workforce. She also oversees policy demonstrations and initiatives that target health, hard-to-reach, high-risk, and disenfranchised racial and ethnic minority populations. Over the course of her more than 30 years in public health, Ms. Cobb Souza has several progressively responsible positions at the state and local levels in Illinois, Ohio, and Wisconsin, at the federal level at the CDC. Johnny Chip Allen is the Director of Health Equity at the Ohio Department of Health. In this position, Mr. Allen is responsible for developing agency-wide goals, objectives, and strategies to eliminate health disparities and promote health equity for all Ohio residents. Additionally, Mr. Allen's work in partnership with national public health organizations, state cabinet-level agencies, and a variety of public health programs to target services to disenfranchised groups, measure program performance, and assess outcomes. So I'd like to introduce to you now Sunseri Cobb Souza from the HHS Office of Minority Health.
Thank you so much. Good afternoon, everyone. This is Sunseri. If you would please go to advance to the next slide, please. I'd like to talk with you this afternoon about one of our very important policy initiatives, as well as to provide information to you before we get started in terms of background for the Office of Minority Health. So starting first with the Omh Mission. Please note that our mission is to improve the health of racial and ethnic minority populations. This is through the development of health policies and programs that will help eliminate health disparities. The Office of Minority Health, or OMH, has 5 major functions. First, they're in terms of increasing awareness, improving the collection and the assessment of data to enhance the understanding of racial and ethnic minority populations' health status, Third, in working collaboratively with our partners and our networks in order to advance health equity. Fourth, to develop, to promote, and to implement the policies, the programs, and practices to improve health equity for all populations. And five, to support research, policy demonstrations, and evaluation efforts. Next slide. Our current strategic priorities include, first, supporting the access to quality health care. Secondly, in leading the implementation of the Department's action plan to reduce racial and ethnic health disparities. And third, to coordinating the efforts of the National Partnership for Action to End Health Disparities, as well as the National Stakeholder Strategy for Achieving Health Equity. Next slide. As one of the OMH strategic priorities, the National Partnership for Action, the purpose is to mobilize a nationwide, comprehensive, and community-driven approach to combating health disparities. The NPA goals of increasing awareness of health disparities, strengthen and broadening the leadership for addressing the disparities, strengthen the health system and improve the life experience for underserved populations, improving cultural and linguistic competency and the diversity of the health-related workforce, and five, to improve the data availability and coordination and to share research and evaluation outcomes. The NPA goals provide all partners with 5 key activities, which, if undertaken, will set each group on the right path to supporting the elimination of health disparities. Now, while several issues must be addressed to eliminate disparities, it is helpful to prioritize. This is to ensure that whether we're speaking of resources in the terms of human resources or fiscal resources, that we can better target them in a way that will allow us to maximize their impact as well as to leverage resources overall. And also, we know that prioritizing has given the NPA more structure. This is in terms of where and how we'll utilize our partners, or work with our partners, as well as utilizing our resources that will ensure that the NPA supports the administration and departmental priorities. Next slide. Now, the NPA structure is comprised of 4 distinct components, starting first with the Federal Interagency Health Equity Team, or known as the FIHAT. The FIHAT is comprised of 12 federal agencies. The FIHAT is co-chaired by the Office of Minority Health, and it convenes federal leaders to end health disparities by building the capacity for equitable policies, programs, funding opportunity announcements, cultivating strategic partnerships, and sharing relevant models for action. The second component is identified as the Regional Health Equity Councils, or we refer to this as the RHECs. The RHECs work to identify key regional health inequities, using their collective power to strengthen cross-sector collaboration. They also initiate new as well as support existing policies and actions to eliminate disparities, to leverage opportunities, and to convene regional stakeholders to address and to plan for the development of health equity plans. There are 10 non-federal, multi-sector regional health equity councils, or RHECs, and they are in line with the 10 HHS regions. The RHECs are independent entities, and the members serve on a voluntary basis. RHEC members include representatives from not-for-profits, state agencies, territorial and local governments, academia, community-based organizations, faith-based organizations, members from the healthcare industry, and the business sector. The third component here are the state offices of minority health, or we refer to them as the SOMs. Now, the SOMs lead the state and territorial efforts to align the state-level health disparities or health equity plans with the NPA goals and the department's or the HHS priorities. The SOMs also serve as a conduit between the RHECs and the state, territorial, and local coalitions. The fourth component here are the national partners. Now, the Office of Minority Health, we work in partnership with national organizations such as ASTHO, the National Conference on State Legislatures, and the National Indian Health Board. This is to expand the reach of the NPA. These national partners play a significant role in raising the awareness and building the capacity among health-related decision makers while strengthening and broadening the leadership for health equity at the local level. Next slide. And we have identified 5 distinct areas in terms of priorities for the NPA. They are 1, promoting access to quality health care; 2, promoting the integration of health equity in policies and programs; 3, educating youth and emerging leaders about the social determinants of health and health disparities, and increasing their knowledge through practical learning opportunities; 4, support the implementation of the national standards for cultural and linguistically appropriate services in health and healthcare, are also known as the National Class Standards; and 5, to strengthen the nation's network of community health workers as a critical part of the disease prevention and health promotion workforce. This is to identify and to meet the needs of our underserved communities. Now, currently, there are 2 cross-regional health equity committees, or 2 cross-RHEC work groups. The first being representing community health workers, or CHWs. The RHECs in regions 1, 5, 9, and 10 have created a cross-RHEC community health workers group to explore national efforts across the RHECs and opportunities for collaboration as it relates to community health workers, or CHWs. The second cross-RHEC work group is one that is the American Indian and Alaska Native Caucus, and the RHECs that are actually formed to address the needs of this caucus, or RHECs, in regions 4 through 10. Additionally, we are supporting the creation of a cross-RHEC, which is focused on opioids. And this will be a work group or a caucus that we are currently working in terms of the creation of this work group across the RHECs. And that's, again, the focus is on opioids. And at this time, I'd like to introduce our next presenter, who is Johnny Allen from the Ohio Department of Health. Thank you.
Hello everyone. I really appreciate the opportunity to share some of the work that we're doing in Ohio. And within this webinar, I'd like to do just 3 main things. I'd like to provide some insight on how to incorporate health equity language into funding announcements. We call them RFPs, or requests for proposals. I'd like to highlight some things that we've learned since 2009 in terms of doing this work and in terms of funding announcements. And also like to talk about how we use some simple technology that we have to keep track of how we're incorporating health equity into our funding announcements so that we can inform future work. I'd like to also thank ASTHO for the opportunity for sharing this information. And I also just wanted to acknowledge right up front is that the Ohio Department of Health really couldn't do this work without many of our internal programs or even our partners in state and other state agencies, as well as our partners who receive our grants who work locally. And so without them, we would not be successful. So I want to thank them as well. as you think about the whole issue of grant making, just offer this slide to show that grant making is everywhere. It's a major way that we actually get money out to our local partners to do the great work in public health. And as you can see just through the slide, there are a number of different organizations and agencies that are actually talking about social justice issues in terms of their grant making. To the bottom, you'll see even they have about grant making with a racial equity lens. So this is something that we are doing that's in alignment with other organizations across the country. So in thinking about what does this mean in terms of Ohio, in state fiscal year 2017, we provide over $160 million for our local grant program. And then in 2018, that's going to total just over $121 million. And we actually have some challenges. Number one, we're 70% federally funded, and so we have different funding priorities from different funders. Also, while our programs have a common mission to protect the health of Ohioans through their very different programs, they lack what's called a syndemic orientation. And CDC defines a syndemic orientation as a way of thinking about public health that focuses on the connections among health-related problems. Consider those connections when developing health policies and aligns with other avenues of social change to ensure conditions which all people can be healthy. And so we really took that to heart, and we wanted to reflect that in terms of our work. Also, as many of you may or may not have, there are health equity experts in terms of programs. We don't necessarily have those infused throughout the entire agency. And also, we need a centralized way to track how we recommend many health equity issues. So I'd like to just ask you to take a moment to answer this poll. How many of you have a specific entity in your organization to advance health equity? It's going to take maybe about 30 more seconds. The responses are coming in. Okay, 10 more seconds. Actually having a lot of really good responses. Okay, 148 have you respond, and let's see. So 71% of you actually have a specific entity in your organization to advance health equity. That's great. For those of you who don't, one of the things I just want to keep in mind is that even if you don't have an entity in your organization, you can still do this work. Here's another poll question we'd like you to answer. If you answer yes to the first question, how often do you collaborate with that office? Okay, we give it about 10 more seconds. A few more. Okay, responses are coming in. Okay, and so if we look at the results, about a little over half actually collaborate often, 29%, almost 30% sometimes, and then there's some that say never. The reason why we want to actually reflect this is because your offices of health equity or minority health, they actually can provide a lot of service, have a lot of expertise to do that, and so we just encourage you to work with them when you can. Now, just going forward, and the key message that I want to also just keep in mind that even if you don't have an office, again, you can still incorporate this into your funding announcements. So one of the things that we definitely want to point out is that there are what we call the 8 equity essentials that if you incorporate these to your funding announcements, you would do well to actually advance health equity. I want to go over them very quickly. Is that when you're thinking about putting these into your RFAs, the first thing you have to ask yourself is what is the extent of the disparity or the inequity that you're trying to focus the application on? you should actually have a way of being able to identify specific groups that experience a disproportionate burden of the disease. You cannot really actually have a health equity intervention without talking about social determinants of health. And you also want to make sure that your applicants really demonstrate a level of cultural competence. So we call these the 8 equity essentials because oftentimes when we look at funding announcements, these things are not necessarily also within the funding announcement. The other piece to this is that in order to understand how well you're in alignment with many of our national health equity planning documents, you would always want some way to link it to a national plan, such as a national stakeholder strategy. So when we think about what we wanted to do in terms of our objectives, we want to be able to make sure that for every request for proposal that comes through our agency, we wanted to make sure that health equity was thought of in the beginning as opposed to an afterthought. We also want to make sure that in all of our proposals that we had our programs and our local partners being able to understand what were the root causes of the inequities that they were addressing. So we had these challenges. On the one hand, differing funding priorities, a lack of endemic orientation, again, not having widespread health equity expertise through all the programs. And the way that we wanted to actually incorporate that is to be able to have a systemic process to incorporate health equity into all of our RFPs. We want to be able that as we work through the RFPs to simultaneously build health equity expertise within our programs. And as you think about this, you have to be able to think about what is the scope of your intervention, and are you trying to incorporate the equity essentials within an individual program area for a specific RFP, or are you trying to work at the enterprise level? These are some of the things that you want to consider. You also want to actually be able to make sure that if you're doing this over and over again for a number of different programs, you want to make sure that your programs actually simultaneously address health inequities and not necessarily duplicate services. Because in many cases, many of your interventions are going to be reaching the same target audiences over and over and over again. Okay, so part of what we need to be able to do is, again, implement a systemic process. We want to be able to make sure that the interventions were broad enough to be able to have an impact on inequities, but were specific enough to be able to address the program objectives for that individual categorical program. And so the big question is, with all of these different strategies, how did we do it? Well, the first thing we did is we had to think about incorporating the equity essentials into the entire life cycle of the grants process. What do I mean by that? Before going further, I like to ask the question, what do you believe is the best place to incorporate health equity interventions in the grant life cycle? In the program design phase, working with your business office, such as a program grants office or your business office, or once the RFP is released? Okay, results are coming in. Just 10 more seconds. Okay. Most of you have overwhelmingly said the design phase of the RFP. Again, some of you have said the business office, and then others, very few of you, about the other 5% said once the RFP is released. Well, I'd like to actually be able to show you that if you think about this as a life cycle, whether or not it's design phase, the program grants office, or once the RFP is developed, the answer to that question, at least from our experience, is that you have to find ways to incorporate health equity within every one of these processes. And we'll talk about that a little later. And I'd really want to also focus on the partnerships too with your grants office and your business office, because depending on who you're dealing with, they can make or break your process. So here, in terms of how we got started, in 2009, the first thing we did is on the left-hand corner you see was called our RFP template. And so every RFP that actually has to be able to come, that's developed, has to use this particular format. And so instead of going to every individual program to be able to work with them on their request for proposals, we first want to modify this document. And when we first started, one of the things that we did, even before we put health equity language in the template, is we went to many of our folks who are actually working on grants on a daily basis, and we asked them, how does this language for health equity pan out for you? And so we actually got their comments and feedback, and based on that, we actually came up with the 4 bullet points that you see on the right. The other thing that I just want to mention at this point is that when we actually started this out, we wanted to make sure not to decrease or increase burden for our programs, that we gave them a 1.5-page statement to let us know exactly their intent to pursue health equity. And the reason why we did that, we borrowed some of the work from some of our partners in health education and the whole issue of the diffusion of innovation theory, because what we really wanted to do is really judge the level of readiness of many of our programs to actually do this work. And so when we start thinking about how do you actually do it, where to focus your health equity language, in most cases when you think about how RFPs are developed, there's a problem need statement, there's a methodology statement talking about how you're going to do the work, and then there's a review criteria. And so we actually wanted to make sure that we focused on those areas of an RFP with these particular bullet points. And so it's very hard to talk about disparity, for example, if you don't know the demographic characteristics of the disparate population. The other thing that we found that was extremely important is that you have to link your methodology for your interventions to the social determinants of health that you're addressing. We also require the standard uses of geography, particularly census tract, because many cases when our programs were talking about where they were going to do their work, they were using zip codes. And zip codes are good geographies to use if that's the only thing that you have. But they're really designed for the efficient delivery of mail. And so it's very difficult to really compare your interventions or even do evaluation because they're not designed, that is, zip codes, to be homogeneous. Now, if you do all of these things, these bullet points, in terms of demographics, talking about the extent of disparity, you have to have a way of being able to know whether or not the folks who are getting the grant have actually did it right. And so we've had to establish specific health equity, a standard in terms of the review criteria to make sure that we were getting what we were expecting from the funding announcement. In this image, I just wanted to bring your attention to a couple things. We embedded health equity language throughout the entire template to make sure that there was some standardization. But the other thing that we did is, if you see in the box, we wanted to explicitly say at the very beginning that our agency was committed to the elimination of health inequities. And we tried to actually list groups within our state that actually experience health inequities and disparities, and even know that they could be a combination of these groups. The other thing that we did is if you look at those 4 bullet points, we actually made sure that we constantly had to reestablish what we were looking for in terms of program content. And I'll go over a little bit more of this in just a moment. Now, the box that you see outlined is we have this tool called a GMIS module, and that stands for Grants Management Information System. And this is the hub, this is the IT solution that actually processes many of our grants. 2 things we want to make sure that people understood: that our health equity initiatives that we wanted to be identified in the grant proposals, that they really need to link to some other planning documents such as Healthy People 2020 and also the National Stakeholder Strategy. And then I'd like to draw your attention to human trafficking. You see that language, and it's very familiar to the health equity language. Well, many of our partners in the sexual assault prevention program saw promise in what we were doing with our health equity language, and so they actually then adopted the strategy and then put language in the RFP template that will compel not only programs but those partners receiving the RFP to actually be able to make sure that when appropriate they were addressing those issues. And so the idea that we had about dealing with inequities really filtered through some other programs. We were glad to see that. This is an example of the IT solution I was talking about. And again, the reason why I want to be able to show this to you at this point is because it's one thing to actually require health equity language in terms of your request for proposals, but we want to actually make a structural change in such a way so that whatever we were actually looking for in terms of proposals, that they will be captured not only in terms of the IT solution, but that we were actually making a change to an IT solution that actually had health equity in mind. And our business partners really helped us with that. So now I want to just really talk about this whole issue of the psychology of seduction. And so here we are. We were actually implementing our health equity language, and I want to show you one other thing. That we were actually looking at this language. We conducted an environmental scan in 2011, and we start to see some things. One of the things that we saw was that a lot of the work that we were doing in terms of health equity, in terms of that statement, that it wasn't necessarily really being reflected in the program content. And we really felt good. We really felt that we had this really important policy milestone. But then as I started looking at some of the RFPs that were posted online, some of them were getting through without the enhanced health equity language. And what we had expected in terms of programs addressing social determinants of health or talking about the extent of inequities, they really did not come through in the way that they should have. And so we found ourselves actually needing a way to really compel the programs that actually want to do the right thing to get the technical assistance that they need. So in this case, I talked about this whole issue of business partners. The reason why this slide is so important is because on the left, you actually see a document which actually is an approval process that every grant has to, or every program has to submit when they are actually working to get their grants approved. And one of the things that you'll see is says that a program has to be able to show that they've had a health equity consultation in order to be able to get their grants through. Well, one of the most important things about this is that the Office of Health Equity did not come up with the solution. Our business partners in our program grants office knew what we're trying to do. We talked to them about RFPs getting through without a health equity consultation. So one of the things that they did is said, okay, well, the way that we can help is we won't even process any of these RFPs until you all have signed off on it. And that was a very important milestone for us. So even though that we thought we had done such a good job in getting the language in, we really need some other partners in our agency to be able to help us take what we knew to be a good strategy in terms of the health equity language, but it needs some enforcement. And this is actually how our partners helped us to do that. And so when I asked the question before, where would it make sense to actually have health equity language? These are some of the phases that we've actually been able to map out that shows exactly the types of things that could actually happen when we're doing the consultation. Whether or not it's in the design phase in phase one, we're just really thinking about the RFP, when they're actually putting the language together. There's also a coaching phase, because sometimes when we introduce language to our partners, we know that they actually need some help in terms of implementing the health equity language, and we also need to make ourselves available once the RFP is released. So we found ourselves actually providing or needing to give experts technical assistance. So how do you do that when experts don't really think that they need it? Before I answer that question, I just want to show you this is the number of grants that we've given out in one fiscal year. So with all of these particularly different grant programs, the Health Equity Office has to review every one of those. So as you can see, that we have a pretty big workload. And just to be able to kind of give an example of how some of this works, here is an example of a health equity consultation that we did with preparedness. We have worked very well with our preparedness program to be able to incorporate health equity in terms of their work. And the way that I can describe this in a summary fashion is we want to actually be able to work with those populations, for example, who would be less likely to survive an event, something like a Katrina or something like any of the national fires and things that we've seen. And so they actually have a document called CMIS. Some of the folks who may work in preparedness may be aware of that. It stands for Communication, Maintaining Health, Independent Safety, and Support. What we were actually able to do is to look at their project narrative and influence how they would actually identify target audiences so that when something actually would, a disaster would happen, they would not only know the priority target audiences they need to reach, but they would have enough information so that the most vulnerable in our community would not be an afterthought in terms of some of the planning. The other example was our tobacco program. As many of you all know, tobacco is one of our major public health issues, and we had a community cessation program worth $12.7 million. And so what we were actually able to do is we were actually able to work with the program with their language to identify not only target audiences that were made vulnerable because of social determinants of health, but we also realized that there, in consultation, that there was data inequity. We would expect many of our local partners to really identify vulnerable populations made vulnerable by social determinants of health, but we necessarily didn't give everybody the same tools to do that. So what we did is we identified, using market research data, we were actually able to identify racial and ethnic minority populations, for example, by census tract, who were more likely to smoke menthol cigarettes. And we gave that information to everyone as part of the RFP so that then they could not really focus on the competition piece of the RFP. That's important. But they can give us the best interventions possible because we gave them the tools to actually be able to do that. And then the last consultation, for some of y'all may have a breast and cervical cancer program. And so what we actually did with them is we actually had a consultation to actually allow them precisely identify women of childbearing age or their target groups that were less likely to get screening. And so we actually used our data to help them target their interventions. But the other thing that came up is that there were some recommendations that the programs came back and said, listen, we understand what you want to do with health equity, and we are supportive of that. But some of the language and some of the strategies that you're suggesting would actually not be as beneficial to us. So they gave us a counter proposal, and it worked out really well. And so, as I mentioned, the whole work with the breast and cervical cancer program and all of our partners, one of the things we had to realize is that in order for us to really have this information, and we want to provide it to our partners, that we had to really think about how do we negotiate with them as program subject matter experts to really get them to understand the scope of what we were trying to do. And it really goes down to a negotiation piece so that we can come up with a win-win situation. So even though we have this requirement that staff developing solicitations have to actually work with the Health Equity Office, we realize that we win and we have a better result when we collaborate. We cannot just wave this big health equity policy stick and expect people to do some of the things that we want them to do. Here's the other piece that I just want to talk about, is that we have all these particular grants, 38 in state fiscal year 18 and 34 in state fiscal year 19. And this is not even talking about those grants that are coming to us on a continuation basis. And so what we had to do is we had to develop a way of actually maintaining our work, because we wanted to be able to, we know that many of these requests for proposals that are coming in are very complex. And we want to be able to keep track of the lessons learned. And so we actually developed this solution. This is a small access database that we actually use to be able to track not only the consultation, but also we want to be able to link social determinants of health and other RFPs together that are actually addressing similar issues. So the reason why this is very important is because we don't necessarily, people leave their positions. Health equity issues tend to change over time. And so we needed to have a way of being able to talk about how did we incorporate those equity essentials, how did we incorporate them each and every time for each situation, because once we begin to start querying information into this database, we'll be able to find synergies that we didn't think existed. And you don't have to have millions of dollars to do this. The staff in the Office of Health Equity actually developed this small access database, and it's working really well for us. So in terms of the lessons learned, because I'm almost at the end of my talk, one of the things we realize is that many of our colleagues really want to advance health equity. They just necessarily don't have the expertise to always do it. And that it is really possible, it's very possible to incorporate health equity into any RFP. But one of the things that it requires is that you really have to understand and value the expertise of the program staff that you're working with, and always know that health equity may not be their primary focus, but there's still a way that you can get that in there. Also, that organizational processes, procedures to compel programs to address health equity, it's possible, but those processes, if you don't have organizational structures to be able to compel that, they're most likely not going to be reflected into the program intervention. So even though people have really good intentions of doing the right thing, unless you have a process, they're less likely to happen. And again, the successful health equity consultations, they occur best in our experience when we were able to show some flexibility from this whole issue of this health equity fidelity or fidelity to health equity principles, and that where we can really work together with our programs to really achieve really good collaboration. So that is the end of my comments. I just wanted to take a special moment to thank Ms. Melissa Lewis for all of her help in terms of helping me organize the webinar, as well as the entire ASTHO staff for always being really supportive of our health equity work in Ohio. We know that we're all in this together, and we just feel grateful that they've allowed us to be able to share what we're doing in Ohio. I think that I have just a couple of minutes for questions.
So we probably can only take one or two questions because we're getting a little tight on time. But the first question we got was from Marvin Key, and he asked, where are the grant notifications posted?
Yes, so thank you for the question. The grant notifications are posted on our Ohio Department of Health website. And so if you would go to the Ohio Department of Health, look under funding opportunities, you would actually be able to see all of our requests for proposals on that page.
And then the next question is, what are the best sites for RFPs related to health, mental health, health equity, and convergence transformation opportunities regarding equity? So where are some of the best sites or resources a person could go to for RFPs related to health and mental health equity?
SAMHSA has some good information on their site, as well as the National Association of County and State NACCHO. I cannot ever get the acronym right. Forgive me, colleagues, NACCHO. But they have some really good tools on their site to actually be able to get some of this work. I would also think that for some of our colleagues who may not have access to a lot of data on populations made vulnerable through social determinants of health, I would also like to recommend Community Commons, which is a really good free open source way of being able to get some of the information and strategies and data that if you don't actually have the infrastructure in your agency to do that, that information is available on that site, communitycommons.org. I think that's pretty much all the time that we may have for questions. I know that do we have a time for one more, Melissa, or we need to wrap it up?
We probably really don't, but one that I can quickly answer is, Corinne had asked, is there a standard template or agenda you use for your health equity consultations? And so that template is what Marianne will be describing, because we actually work closely with Ohio to create a health equity template, and that is the 8 equity essentials. Am I saying it right? The 8 equity essentials that you coined that phrase. So that template that she's about to discuss is also a useful tool for discussion. So thanks so much, Chip, and I'm going to...
Thank you, Chip. That was great. Melissa, if you want to skip over this slide, just go quickly to the next. No, back up. So I just want to give you a real case example. I know that Chip gave you a couple of examples, but I want to share a little bit about what happened with in New Hampshire, when it was a totally unexpected consequence of having a health and all policies approach to looking at policy. I had the privilege while I was in New Hampshire as Associate Commissioner, to lead the health and all policies, and it really was a collection of legislative liaisons and lawyers that were responsible for designing and developing legislation and some of the policies related to the the executive branch of government. And while participating in this particular committee, and we would meet regularly to look at each other's policies, we would look for opportunities to support each other in what we each were doing, and of course to include health in and the concepts of health and health protection, health promotion into any other policies that might be relevant. The Department of Transportation asked me if I'd like to participate in their request for proposals for community-based grants. And these grants many of them were infrastructure development, but some of them also were for initiatives such as safe routes to schools and building safe corners where there might be traffic violations, a number of traffic violations. And during the course of the discussions, I realized really soon on in the review of the previous RFP that nothing was included about health, or nothing was included about the public health implications of whether or not you wanted to build a bike path, or whether or not there was a real need for having the particular corner redesigned or whatever. They asked for things such as, how many accidents occurred, but they never talked about what is the profile of the community, what's the demographic, what are the, issues related to social determinants of health within these communities. So brought it up to the entire committee, and it was I think Chip described it in one of his slides, it was an opportunity for education. And it was an opportunity really to get them to think in a very different way, in a very purposeful way, about how to consider when you're putting money out into communities, what are all of the ramifications of what could possibly happen with improving the lives of individuals in those communities. In public health, we think about it naturally. But in the Department of Transportation, some of these old-timers really had a little bit of difficulty wrapping their head around, well, why would we want to talk about, what's the racial profile of folks living in a community? what is the socioeconomic needs within a community. So one of the very concrete references or resources I would ask them to include into the RFP was to have them look toward their community health needs assessments, contact their hospitals and others that might have information relative to the needs within communities. And it was, all in all, a really great experience, to the point that even on judging or scoring them, extra points were given to communities that demonstrated that they had included information about the public health or health equity needs within that community. So that's one really good example that I also wanted to share to add to what Chip has already shared. So now I'm going to go into just very briefly to talk about the funding announcement tool that we are putting forth here today. And this will be made available to anybody who will be on our website if it already isn't, and it will also be the first of a couple of tools that we'll be sending out this year under our agreement with the Office of Minority Health. We were privileged to be able to work on some of these things that are very tactical approaches to improving health equity in states. And so within this particular funding opportunity announcement, it includes a glossary and examples of the health equity activities that folks might want to promote. We heard from our members when we did a survey that folks really needed this kind of a tool, and when we reached out to CHIP, they helped us design this very specifically with all of the information that you just recently heard. The guide begins with these common set of abbreviations, and it concludes with several examples of state and federal agencies that have incorporated health equity requirements in their strategic plans and RFPs. The sample language within the template is designed around these 8 main ideas: to explain the type, to identify, describe, explain again and identify social determinants of health, outline the steps that could help to achieve it, explaining again the program evaluation and outcome measures and benchmarks, and then providing linkages to resources such as the National Stakeholder Strategy for Achieving Health Equity Goals. So we have only a few more minutes, and I'm going to go to Melissa again and see if she can check out some more questions that might come our way.
Okay. So thanks, Marianne. So the guide that Marianne mentioned, it will actually be posted, if not later today, it'll be posted tomorrow, but we'll make sure to share this with everyone. It will be under programs for health, and it's health equity. So if you go on the ASTHO website, there's a page for health equity, and you will see the template as well as the guide, and so that is in the queue to get posted. If it's not on now, it'll be up by tomorrow, and so please check it out. And also, just for your reference, there will be there's a map up there of different examples in states and territories of health equity activities and initiatives. So if your state, if you know there's some great work happening and you would like it added, please send it my way, and then we will get that information posted and up on that map. I know it's quite helpful, and there's a lot of great ideas. So let's see if we have another question. There was a question talking about are there opportunities to look at equity goals for LGBTQ, disabilities, etc. And so there definitely are opportunities to look at those things, and ASTHO will be taking a comprehensive view and not just looking at racial and ethnic disparities and disadvantage, but we're also going to be looking at geographic, income, looking at housing, disabilities, LGBTQ, all of those things. So those are all in, and if you have things to share with us, to put on the map, it can cover all of those areas. So it's not exclusively for racial and ethnic disparities.
And if you go straight to the ASTHO website and put in the search box up at the top right-hand corner, you'll see Health Equity Snapshot Map, and that will bring you to the area where you could submit some of your ideas.
And Chip, did you also want to say anything about that question? Is there any work happening in Ohio related to some of those other areas?
Yes, it is. Very briefly, when we look at an RFP, we don't necessarily look at it just in terms of one community. So we have a very large Appalachian population in Ohio. And, of course, we have LGBTQ people there as well. And so one of the things we do is we look at the problem, but there are plenty of opportunities for us to be able to bring in other communities that experience inequities into the focus. And so I'm glad you brought that up because the question came up because there is no one problem that just impacts one particular population made vulnerable through social determinants of health. And so, but yes, we do that, that cross-collaboration. And in one of the slides, when you saw the piece about the information system, we actually are now trying to collect the information from the RFP on the different types of groups that RFP is focused on so that we can bring that cross-collaboration together in a more scientific way.
Thank you. Well, we need to wrap up.
So, yeah, we want to thank everybody for joining today's call. Here's the contact information for all of the speakers, and so we will be sharing the slides out with everyone. And we ask that you participate in an evaluation to briefly let us know what you thought about the webinar and ideas for future webinars. And then we also want to let you know that coming soon, probably either late March or early first week in April, we will have our next webinar, which is about multi-sector intersections and collaborations to advance health equity. So stay tuned for more details. And thanks, and have a great evening.
Thank you, Chip.
Thank you all.
And also, we will be responding to any other chat questions via email. We'll send that out in the materials that the post-webinar materials. So we will try to answer all those questions.
Have a good afternoon, everyone.